Dear colleagues, I am Professor of Cardiology Mekhman Mamedov, Head of the Department for Secondary Prevention of Cardiovascular Disease at the National Research Center for Internal Medicine, one of the leading Russian research medical institutes. First of all, I express my gratitude to the organizers of the Congress of Cardiology in Japan. The program includes reports and lectures from more than 25 countries in various topics of cardiovascular disease. My lecture is devoted to the prognosis, acute and chronic forms of coronary artery disease in type 2 diabetes after revascularization, but I will talk more broadly about the problem of coronary artery disease and diabetes around the world. There is no conflict of interest. Recently, in PubMed, I analyzed publications from the 70s of the last century to the present time using the keywords diabetes and coronary heart disease. It turned out that over time this problem becomes more relevant. Published 5,200 articles during this time. Over the past 5 years, the number has increased. In the 60s, last century, the main risk factors for cardiovascular disease were considered as smoking, high cholesterol, high blood pressure. After 40 years, come to the 4 metabolic disorders such as obesity, metabolic syndrome, and diabetes. Of course, together they increase the risk of cardiovascular complications. The WHO has declared diabetes a pandemic. The table lists 10 countries where the prevalence of diabetes is high. The top 3 are China, India, and the United States. And in 20 years, this trend will continue. In South America and Southeast Asia, diabetes is also expected in double. Last year, the number of people with diabetes is expected to increase to 700 million worldwide. This picture clearly shows that in the European region, Russia, the Baltic states, and countries of Eastern Europe are the high diabetes risk. The prevalence is more than 80%, while in the Western and Central Europe, the prevalence of diabetes mellitus is 4–5% among the adult population. One of the reasons for the relevance of diabetes is its high proportion among patients with cardiovascular disease. According to the classical multi-center Euroheart survey, in which 25 countries took part, it was revealed that 20% of patients with acute myocardial infarction have diabetes, and 40% have prediabetes. According to Professor Thomas Luscher from Switzerland, type 2 diabetes mellitus was diagnosed in 25 30% of patients admitted with acute coronary syndrome. In the 40% of patients who adverted coronary artery bypass graft. Eurospire study has been demonstrated a positive trend in the reduction of arterial hypertension and hypercholesterolemia, while the frequency of diabetes mellitus, including the new diagnosed diabetes, is increased. In another classical study, prospective health study, cardiovascular risk in different diabetes stages was estimated. It was shown that cardiovascular risk outpaces diabetes incidence on 10 years. On the early diabetes stages, cardiovascular risk 3 times higher compared with patients without diabetes. It is known that the complications of diabetes include the increased risk of heart disease, stroke, hypertension, retinopathy, renal disease, and neuropathy. Totally, these complications of diabetes mellitus divided to two groups: macrovascular complications and microvascular complications. So, macrovascular disease are the main causes of the death in diabetes patients. Thus, 55% of patients die from myocardial infarction complications and about 30% because of stroke. The last years, cancer's incidence increase in diabetes patients too. There are a number of international guidelines for the management of patients with diabetes and cardiovascular disease. As the data from large studies accumulated, target levels of important indicators, methods of diagnosis and treatments are updated. The most widely we use the recommendation of the European Society of Cardiology. Also, the recommendation of the American Diabetes Association for the treatment of risk factors and CVD update annually. What is the current opinion on revascularization of patients with diabetes and coronary artery disease? The key points are listed below. Angiographic studies has been shown that the patients with type 2 diabetes mellitus are more likely to have stenosis of the trunk of the left coronary artery and multivessel CHD with the involvement of small blood vessels. In addition, patients with type 2 diabetes mellitus have high atherosclerosis burden and increased number of lipid-rich plaquettes with high likelihood of rupture. Silent myocardial ischemia occurs more often among patients with type 2 diabetes mellitus compared with those without carbohydrate metabolism disorders. The predicted surgical mortality, anatomical feature of coronary lesion, and the possibility of complete revascularization are important criteria for the choice between PCI or GAPS. The decision of the preferred treatment method depends on the assessment of the risk-benefit ratio of the intervention, classifying the risk of complications, dynamics of the life quality, and long-term prognosis includes the risk of myocardial infarction development. We recently completed a small prospective clinical study examination, the one-year prognosis in individuals with acute and chronic cardiac heart disease in diabetes after revascularization. The study was conducted at the Russian National Center for Internal Medicine. The aim of study to analyze the features of myocardial revascularization in patients with acute and chronic forms of CHD in combination with diabetes mellitus to assess complications after 1 year of observation. Materials and methods. A prospective clinical study included 202 patients in age diapason 35 and 65 years, or both sexes with acute and chronic forms of CHD. Depending on glycemic status and form of CHD, patients were divided into 4 groups. First group, acute form of CHD and 2-type diabetes mellitus. Second group, acute form of CHD without type 2 diabetes mellitus, is a control group. Third group, chronic forms of CHD and type 2 diabetes mellitus. Fourth group, chronic forms of CHD without type 2 diabetes is the control group 2. Myocardial revascularization. Depending on the clinical condition and the result of coronary angiography, patients underwent various types of myocardial revascularization. Balloon angioplasty without stenting, coronary bypass grafting, and stenting, then coronary bypass grafting. Endpoints. 1 year after discharge, all patients were called to assess complications and endpoints, which include the following incidents: recurrent myocardial infarction, acute cerebrovascular accidents, readmission, revascularization, death. An assessment of the total indicator of the endpoints was carried out. In patients with a chronic form of CHD in history, myocardial infarction was registered 2 times more than is the acute form of CHD. Every third patient with chronic coronary artery disease and diabetes have stable angina. And in the group without diabetes, every second patient had stable angina. In patients with acute coronary heart disease and diabetes, unstable angina was detected in every second case, and in patients without diabetes in 80%. Whereas myocardial infarction without ST segment elevation in patients with acute coronary heart disease and diabetes was detected 2 times more often than in group without diabetes. The number of stents was by 50% higher among with acute coronary heart disease without diabetes mellitus compared with those with diabetes mellitus. 65% versus 42%, as different statistically significantly. Patients with chronic CHD showed similar patterns. Stenting was performed in 61% of patients without diabetes and in the 35% of patients without diabetes. This difference was significantly too. GAPS frequency ranged from 8% to 18% among patients with acute and chronic forms of CHD. The frequency of this procedure did not differ significantly between the groups. The frequency of the combination of intervention, GAPS followed by PCI, was comparable between those with and without diabetes mellitus. Angioplasty without stenting was performed among 4-6% of patients with diabetes mellitus. No patients from the control group underwent this procedure. In the group without diabetes, the number of patients with 1 stent was 2.5 times higher compared to groups with diabetes. The groups did not differ in the frequency of implantation of 2 or more stents. In general, the number of revascularization in all groups was comparable, ranging from 72% to 78%. Myocardial revascularization was not performed in 25% patients for various reasons, including subjective ones. I want to demonstrate 2 cases of visual picture of coronary angioplasty and revascularization. A 64-year-old family with history of CHD, class 3 stable angina and type 2 diabetes. Chronic distal left circumflex coronary artery, arrow 1, occlusion and 90% large marginal branch stenosis, arrow 2. You can see PCI with large marginal branch stenting was performed. Stress echocardiography was used to assess the severity of transient myocardial ischemia as a need of chronic left circumflex coronary artery occlusion recanalization. Stress test was negative and left circumflex coronary artery revascularization was not performed. Second cases, 58 years of male with history of right coronary artery stenting 3 months ago, present with fatigue and shortness of breath at the rest. EKG showed ST elevation in second, third and IVF segments. The patients missed 3 days of double antithrombotic therapy and developed stent thrombosis. This arrow you can see. So report high coronary artery stenting was performed and the patient was instructed on treatment adherence. The aim of the study was to analyze endpoints in patients with acute and chronic CHD and diabetes mellitus. In both groups, recurrent myocardial infarction was detected 2 times more often among patients with diabetes compared with control group. Recurrent myocardial infarction was detected 2 times more often among patients with diabetes compared with control group. The frequency of stroke was up to 5%. 1-year mortality in patients with acute and chronic CHD was 8%, about 2% in patients without diabetes mellitus. Readmission was observed 2 times more often in patients with diabetes mellitus compared with control groups. It is noteworthy that patients with acute and chronic CHD required repeat revascularization 3 times more often than patients without diabetes mellitus. This difference in patients with chronic CHD was statistically significantly. And in this slide you can see the total number of endpoints. The total number of points is in patients with acute and chronic CHD and diabetes mellitus was 2 and 5 times higher compared with those without diabetes. This was statistically significant in both cases. So, take home message. The majority of patients with acute and chronic forms of CHD, regardless of glycemic status, underwent myocardial revascularization. In patients without diabetes mellitus, stenting prevalent, most often one coronary artery. At the same time, coronary bypass grafting, as well as a combination of these 2 procedures, was performed in diabetes patients along with stenting. After a year of the observation, the number of complications in diabetes patients was 2 times higher than in diabetes without diabetes, which emphasizes the importance of secondary prevention, including complex pharmacotherapy. Dear colleagues, based on results of this study, we published at the end of the last year in the journal Cardiac, and as is public domain for review. You can analyze this article too. And total conclusion: type 2 diabetes mellitus is a serious medical and social problem worldwide. Cardiovascular disease continues to be the main complications of diabetes. Timely primary prevention among people at the high diabetes risk can effectively reduce the likelihood of developing it. International experts consider diabetes to the analogs of coronary artery disease. Therefore, patients with diabetes should be considered at a high-risk group. Patients with diabetes mellitus are more likely to have stenosis of the trunk of the left coronary artery and a multivessel lesion of coronary bed with a more diffuse lesion of the small branch. Painless myocardial ischemia is common among diabetes patients. Pharmacotherapy in diabetes and CVD should be complexly include effective control of blood pressure, lipids, antiplatelet therapy, and glycemic control. Myocardial revascularization more effectively reduce the severity of clinical symptoms, increase the quality and duration of life. For patients with diabetes mellitus and multivessel coronary artery disease, coronary bypass surgery is preferred. The presence of severe comorbidity, advanced age, and the syntax between 0 and 22 score indications for PCI revascularization. Dear colleagues, based on the results of many years of work, our team published the book Atlas of Angiographic Patterns in Patients with Diabetes. 10 chapters present images with angiography and stenting of the coronary, carotid, peripheral, and renal arteries. About 200 clinical cases are presented, which may be useful in the cardiology practice. As sign of the goodwill and in agreement with the organizers of this Congress, we will send the electronic version of the book to all participants of this Congress. Also, I invite all participants to publish original review articles and clinical case in the International Hand and Vascular Disease Journal. It is quarterly peer-reviewed journal published in English. Publication for author is absolutely free of charge. You can submit articles in all topics of cardiology. More information you can find on the official website of the journal. This is the panorama of the main attraction of Moscow, Red Square. Thank you for attention. This is a high mountain in Japan, Mountain Fuji, one of the main symbols of Japan. And I want to say thanks you in Japanese. Seicho, arigato gozaimashita.